Welcome to Renus Care Radio, a podcast for nephrology professionals. Hyperkalemia, characterized by elevated serum potassium levels, is a common and potentially life-threatening complication in patients with chronic kidney disease. The kidneys play a crucial role in maintaining potassium homeostasis, and their impaired function in CKD leads to an increased risk of hyperkalemia. Effective management of hyperkalemia in CKD patients requires a comprehensive understanding of its pathophysiology, risk factors, and treatment strategies. The kidneys are essential in regulating potassium balance by filtering and excreting excess potassium through urine. In CKD, the decline in glomerular filtration rate reduces the kidney's ability to excrete potassium, leading to its accumulation in the blood. Additionally, CKD patients often have other conditions that contribute to hyperkalemia, such as metabolic acidosis, which shifts potassium from intracellular to extracellular compartments, and the use of medications like renin-angiotensin-aldosterone system, RAS, inhibitors that impair renal potassium excretion. Several factors increase the risk of hyperkalemia in CKD patients. The severity of kidney dysfunction is a primary factor, as a lower GFR correlates with a higher risk of hyperkalemia. Medications such as RAS inhibitors, potassium-sparing diuretics, and nonsteroidal anti-inflammatory drugs, NSAIDs, can impair potassium excretion. Dietary factors also play a role, with high dietary potassium intake from fruits, vegetables, and salt substitutes increasing risk. Comorbid conditions like diabetes mellitus, heart failure, and metabolic acidosis exacerbate hyperkalemia, and older adults are at higher risk due to decreased renal function and comorbidities. Hyperkalemia can range from asymptomatic to severe, life-threatening conditions. Symptoms include muscle weakness, fatigue, paresthesia, and cardiac arrhythmias. Severe hyperkalemia can lead to cardiac arrest, making early detection and management crucial. Diagnosing hyperkalemia involves measuring serum potassium levels, with levels above 5 millimole per liter indicating hyperkalemia. Electrocardiogram changes, such as peaked T waves, widened QRS complexes, and sine waves, help identify the severity of hyperkalemia and guide treatment decisions. The management of hyperkalemia in CKD patients involves both acute and long-term strategies to prevent recurrence. The treatment approach is guided by the severity of hyperkalemia and underlying causes. The initial step in managing acute hyperkalemia is to stabilize the myocardium with intravenous calcium gluconate to prevent arrhythmias. Potassium can be shifted intracellularly using insulin and glucose, beta agonists, such as albuterol, and sodium bicarbonate in cases of acidosis. Potassium removal options include diuretics, sodium polystyrene sulfonate, and dialysis in severe cases. Long-term strategies focus on dietary modification by educating patients on low-potassium diets and avoiding high-potassium foods and salt substitutes. Medication adjustments are necessary to review and balance medications that contribute to hyperkalemia, such as RAS inhibitors. Newer potassium binders, such as patiromer and sodium zirconium cyclosilicate, offer effective long-term management options with fewer gastrointestinal side effects compared to traditional binders. Regular monitoring of serum potassium levels, kidney function, and medication review is essential to prevent hyperkalemia. Hyperkalemia is a significant concern in CKD patients, necessitating prompt and effective management to prevent severe complications. A comprehensive approach that includes acute interventions, long-term management strategies, and patient education is essential for optimal care. Thank you again for joining us here on Renus Care Radio.